Hello, everyone. It's a pleasure to be with you today. I really enjoy speaking on this topic of optimizing polypectomy because polypectomy is such a central skill for us in gastroenterology. I know that in the virtual audience, there's a lifetime of experience in polypectomies. I'm sure hundreds of thousands of polypectomies. So I'll share my thoughts on what I think the perfect polypectomy should look like in 2024. And hopefully during our discussion session, we can have some discussion and maybe some argument about it as well. These are my disclosures. So I'm going to begin and end with a visual that I think is a really, really helpful and realistic, practical framework to think through polyp and polypectomy decisions. This is a guideline from the American Journal of Gastroenterology in 2020, and over the course of the talk, we'll walk through essentially each step of this guideline, how we think about non-pedunculated polyps of various sizes, pedunculated polyps, and how we assess ultimately for concerns for early invasive cancer and how that might change decision making. But this is a good image to bookmark and one that we actually have posted in our endoscopy suite to make sure everybody is sort of swimming in the same direction on our team about how polyps should be dealt with. So the way I think about this is that each polyp really represents a wealth of opportunities to make a mistake and an opportunity to do better. The small flat polyp, our risk here is primarily incomplete resection. The large pedunculated polyp, our risk may be difficult to control bleeding. With a big bulky polyp, a major risk is an impacted snare, which is sometimes the scariest situation you can get into in the endoscopy suite when you're doing one of these procedures. And then the large flat polyp has a whole bunch of challenges from trying to resect without fully planning how to do it, potentially taking unnecessary biopsies, poorly placed tattoos, not thinking about the bleeding risk adequately. So we'll talk together today about how to mitigate each one of these risks. The reason that we have to care about this is that incomplete resection is a real concern, and if we remove 90% of a polyp, whether it's a small polyp of 6 millimeters and we get 5 of them, or a larger sessile polyp, it can look reasonably good, like we've done a reasonably good job. We may not necessarily see that there's any residual polyp left, but there is polyp left. And if that old small amount of polyp grows for another 5 years or 10 years, it becomes a much older polyp, even if it's a relatively small polyp fragment. And we know that interval cancers can occur at sites of partially removed polyps. So we have to be very, very thoughtful about complete resection. So talking about complete resection, let's first just dig into the likelihood of complete resection in regular GI practice for, say, an 11 millimeter sessile polyp. And I'll allow you to make your own estimates here of what you think that likelihood is, and then I'll show you the data, which I think is somewhat humbling. So one of the best studies in this space was published now about a decade ago, and they took about 1,400 patients, all of whom had a sort of medium-sized polyps, 5 to 20 millimeters. And these were all very, very experienced endoscopists, and they were asked to completely resect the polyp using their preferred methods, and then to take some additional biopsies at the resection edges. And the somewhat surprising finding was that the incomplete resection rates range from the best quartile of just 6% to the worst quartile of 23% of residual polyp. And there were 4 factors that were associated with incomplete resection. Doing anything piecemeal was more likely to lead to incomplete resection. This sort of intermediate size, as opposed to a much smaller size, was higher incomplete resection. Sessile serrated adenomas were a particular problem. And then I think the most important thing that we have to all recognize is that the endoscopist was one of the factors that was associated with incomplete resection. And one of the, I think, key take-home points for a study like this is that I think that all of us have an opportunity to move towards the highest quartile or highest quintile of performers for complete adequate resection of all polyps. And that's a big part of what we're going to be talking about today. En-bloc resection is clearly best when it's feasible, and even small polyps can present a challenge. So let's start with these small polyps and figure out how best to address those. Often in polypectomy lectures, a big part of the lecture is sort of this, gee whiz, look what I can do, look at the largest polyp I've ever removed. But I think that's actually really not the most important polyp in GI practice. The far more important polyp in GI practice are the ones that we all encounter every day. And I would argue that the small sessile polyp, getting that right, probably has a bigger impact on patients in general than being able to, take off that 6-centimeter giant. So the small sessile polyp is very commonly encountered during colonoscopy. We know that it can be resected incompletely, especially if we do piecemeal or forceps attempts. And I mentioned that concept of the biologic age of the polyp, leaving a little bit of polyp may be bad news. So how do we want to take this off? We have a couple of choices. Historically, we would use cold forceps. Now we're moving much more towards cold snare. Cold forceps certainly has its appeal. It's generally fairly fast and safe and easy. The disadvantage is that you get a smaller amount of tissue resection compared to the snare, but some people really like it because you'll always get the pathology sample. You won't ever lose it. You don't have to go sort of fishing around for it as you do with the snare. But I would argue that it's actually far more important to have a complete resection than to actually have the pathology specimen. So if you're using a cold forceps just because it guarantees you keep the small pathology specimen, I would say that we have to sort of change our goals. The cold snare really is a preferred device now for most small polyps, and the big advantage is because of the design of it, we can take a halo of clean, healthy tissue around a true negative resection. We all know the disadvantage. Sometimes the polyp flies in a different direction, and we can sometimes even lose it and spend time searching for it, and that can be a little bit of a hassle. But critically, we're much more likely to get a complete resection, and that ultimately has to be our goal. In terms of the technique, this generally really does work best with a dedicated thin wire cold snare, and these are able to cut through tissue much more smoothly than a lot of other snares. The goals here, which are a little bit different than a traditional hot snare polypectomy, number one is we typically want to keep the lumen fairly inflated. This limits any submucosal trapping. We'll typically want the scope tip down and the snare sheath pushed forward as we close. And we want to intentionally take a surrounding normal tissue margin. So let's look at what this looks like during an actual procedure. We have a small sessile polyp at 6 o'clock. We're gradually inflating the lumen and adjusting the snare at around the 6 o'clock position. And now, as the snare closes, we'll push the sheath forward a little bit and aim to take up extra tissue. This, as you're looking through it, you might say, oh gosh, that's a whole extra, half centimeter or centimeter of extra tissue. But with a cold snare, it's safe and it just guarantees that you've got plenty of healthy negative margin. A couple of additional tips when we're doing cold snares. One is to look for the halo sign, or some people call it the Saturn sign. I had a fellow call it the fried egg sign, but you want to see a healthy tissue margin around the polyp after the cold snare polypectomy. The other very useful tool is to use the water jet after the polypectomy. And the water jet, you can actually expand the submucosa. And it basically sort of expands the entire mucosal defect. It not only slows bleeding, creates some tamponade effect, but also effectively everts the edges and allows for more clear evaluation if you're concerned about any residual polyp. So that water jet basically gives you a submucosal lift after the cold snare, and that can be very, very valuable in inspecting the site. A variety of national and international guidelines have really sort of moved strongly towards moving that cold snare be our dominant approach for diminutive polyps. The ESG guidelines in particular say you can use a biopsy forceps, but really it should just be for really tiny, less than 3 millimeter polyps, and then only if the snare is not technically feasible. And I think that has it just about right. For most small sessile polyps, cold snare really should be what we're doing. The big advantage of cold snare is there is no delayed bleeding. You might see some oozing at the time of. Usually, if you wait for a few seconds, it's done. But delayed bleeding happens essentially never. All right, so our next challenging polyp is this large pedunculated polyp. And the big concern with the large pedunculated polyp typically is that there's going to be a blood vessel in this stalk, and we're worried potentially about bleeding that sometimes could be fairly dramatic right after this polyp comes off. So what should we do about that? Should we prepare ahead of time by injecting, by using a detachable snare or endo loop, by clipping? What's the best approach? We really have three or four choices. The three choices are the detachable snare, preemptive hemoclips towards the base, or an epi injection. And the fourth choice is to do none of the above and just snare the polyp and then take whatever happens afterwards. If there's bleeding, we deal with it afterwards. It turns out I think they're actually all very, very reasonable approaches, but let's talk about a couple of them. There was a randomized trial quite a few years ago now looking at large pedunculated polyps with a thick stalk, whether it was better to clip the base or to use an endoloop. It turns out those are equivalent. So either approach that you feel most comfortable with is completely fine. One of the challenges with the endoloop is that it is not the most obvious device to use. And we tend to joke in our unit that we have to bring 2 or 3 endo loops in the room if we're going to be using. One is to practice on. The second is to deploy accidentally and harmlessly next to the polyp because it just didn't go right. And then with a third endo loop, you finally get it right. But there's actually a secret to getting this right, and it's the 4-step ABBA method. And the way we think about this is that, and I'm going to show you a video in just a moment. The first A is that the yellow cylinder has to be moved away from the handle. This effectively sheaths the snare. The snare comes open in the package. Once we're out in front of the polyp, we now move the yellow cylinder back again towards the handle. That opens the snare in the lumen. And now we start using it more like a regular polypectomy snare. Once we're around the polyp, then we use the handle slider back towards us. That's the third B, to close the snare around the polyp. And then we open the handle slider to release the polyp. The big challenge for these is that steps 3 and 4 are irreversible, and that's what gets everybody hung up. Steps 1 and 2, you can go back and forth sheathing the snare as much as you want, but once you close the snare, this step 3, and then release the snare, step 4, those are irreversible, and so that's a little bit different than a traditional polypectomy snare. Here's a video of the ABBA method. Again, the snare comes open in the package. We're going to use the yellow cylinder away to bring the snare into the catheter. Now we're going to bring the yellow cylinder back towards the handle to open the snare, at this point over the polyp. And now we'll use it more as a traditional polypectomy snare. The handle slider will close. And this is a one-directional thing. You cannot open anymore because steps 3 and 4 are irreversible. And then we'll move the handle slider away to basically release the whole instrument onto the polyp. And this has the benefit of strangulating the stalk of the polyp before we move on to do our polypectomy. So for the large pedunculated polyp, ultimately you have choices. You just have to be prepared and do what you're most comfortable with. For a thin stalk, I typically just snare it and have clips ready just in case. And if it's a really thick stalk, I choose between any of these options, frankly. Sometimes we'll just snare it, and I might use epi pre-injection beforehand. I may use clips afterwards. Or if there's a really, really big stalk, we can attach clips to the base and cut above that, or attach the detachable snare prior to the polypectomy. They're all reasonable choices, but I would generally advise you to get comfortable with a detachable snare because it can be a useful device, even if it's a little bit of a headache to get used to. All right, so there are no moments that are sadder in your life as an endoscopist than the impacted snare. So you come across a 4-centimeter semi-pedunculated polyp. You think you've got the whole snare around things. You start pressing on the cautery, and nothing seems to be happening. You press for a little while longer. Some thoughts start going through your head. You ask the team to check the cautery unit, maybe to adjust the cables, make sure everything's attached. You maybe sort of try to jiggle the snare back and forth or try to open it, and now it's really not opening. You're not able to get off the polyp. And now your day is ruined and you have an impacted snare. This happens to all of us. It's not incredibly frequent, but when it occurs, it's really, really memorable. And I would wager that most people in the room have seen this or had it happen to them. And it's important to know what to do about it when it occurs. So there are 4 steps for troubleshooting a snare that just won't go through. The first is to do what I mentioned, check the circuit, maybe exchange the grounding pad or the wires. You may add a little bit of a cut or blended current. We typically use the EndoCut generator setting on the Irby unit, but there are a variety of other units that have equivalent settings. You can try opening that snare and releasing the polyp, but if it's partially embedded because it's cauterized partway through the polyp, you're in trouble. And then if steps 1 through 3 don't work, that's when you have an impacted snare and you're not a happy person. But all is not lost, and there are ways to approach this. Basically, there are 2 standard approaches to dealing with the impacted snare. And the first approach is to cut the snare at the channel. There's a picture of a scissors here, but you actually have to cut it with a wire cutter. It's very important to have a wire cutter available in your endoscopy unit. You can get one at Home Depot this weekend if you don't have one. And once you've cut the snare all the way through, then you can withdraw the scope. And at that point, you can reintroduce the scope and just use a new snare to begin basically a piecemeal resection methodically down. It can be a little bit messy. You're not getting to the base of the polyp, but usually with piecemeal, you can work your way down and release the original snare and hopefully remove the whole polyp. The approach number 2, which is a little bit fancier and maybe the better approach if you're really convinced there is some sort of stock that you would love to get down to, is once you cut the old snare, you can thread a second snare over the wire of the old snare, and that will actually allow you to get fully down to the base if you're convinced that there is a stock that you need to get to. And then once you've reached the base, then you can try resecting again. There is a third approach that's important to know about, and it is maybe not your ideal option, but it's a safe option, and it's mentioned in actually one of our major GI textbooks, and that is alternatively, the patient can be admitted to the hospital until the original snare falls out and the enclosed polyp sloughs off. Now, that may not be a conversation that you're looking forward to having with your patient. If you leave the snare there, you have a wire taped to their butt and you have a conversation in the recovery room about what the heck happened. But the important thing to know is that it may be an embarrassing conversation, but that is still a safe situation. You haven't pulled too hard, you haven't torn anything, you just have a stuck snare. And if you leave it there, it often can fall off after a couple of days. And if you can't fathom that option, then you can have a colleague go back in the next day, or if you're sure the polyp is really ugly, you can have a colorectal surgeon deal with it the next day. But it's a safe, albeit maybe embarrassing option, but it is important to know that is a consideration if you just can't find a way to get that snare off. All right, so the large sessile polyp, this is often the one that most polypectomy and EMR talks are all about, and it's often what advanced endoscopists like myself are most interested to talk about. And there is a lot to discuss here and a lot of potential errors to make. When I think about encountering the large sessile polyp, I think a couple of questions. The first question is it endoscopically resectable at all? I'm typically inspecting for signs of invasive cancer, and I'll show you how to do that in just a moment. And if I do think it's resectable, and the second critical question is it endoscopically resectable by me today? Do I have time in my schedule to do this? Are my staff ready for this? Do I have the right equipment? Have the patient and family been properly informed of EMR risk? If I have a screening colonoscopy list, I'm not necessarily talking for 20 minutes about the risks of EMRs. And I'm not always asking patients whether they're, for instance, traveling out of town, tomorrow. But for an EMR or any complex resection, we typically do have those conversations. So if I'm not ready for it or I haven't discussed it with the patient, that EMR should typically be at a different time. So let me show you a picture of a sort of a medium-sized sessile polyp that we might encounter, and then we can decide together what to do about it. This is going to be looked at in both white light and narrowband imaging, just doing a careful inspection of the polyp here. This was referred for possible EMR. And the question is, do we need to lift it? Do we need to do a regular hot snare? Should we tattoo it? Should we biopsy it? What should we do here? The way to sort this out it starts with some careful polyp inspection. And I'll show you in a moment that this polyp has some worrisome signs on the NBI pattern. Looks like there's some interrupted vessels on the surface. It looks a little bit depressed. I'm worried that this may be an invasive cancer. So how do we think about that? And how do we think about the assessment? This is a murky, challenging area for American endoscopists. Across the world, in Europe, Japan, elsewhere, people spend a heck of a lot of time on Paris classification and NBI classification schemes. In the US, it's generally not been a practical and reliable approach, and there's huge amounts of inter-rater reliability over whether people can really use Paris classification or NBI or JNET classifications. And I'm going to tell you in the end that I actually think that we shouldn't stumble over the details of these classification schemes. But it's still important to be generally aware of, and I'll talk to you about how I think you can incorporate it in real life into your practice. So the Paris classification is basically just describing morphology and shape. Is it polypoid? Is it flat? Is it depressed? Those are that's the general theme of the Paris classification. And I think it's frankly completely fine to call something pedunculated or slightly depressed without remembering that it's Paris classification 2C. Similarly, there is a mucosal inspection classification scheme. There are a variety of them, but the simplest one is the NICE classification, and it uses NBI patterns. The basic concept is that if you're trying to inspect a polyp and sort out if it has a likely invasive component, if you put NBI on, you can basically look at the surface blood vessel pattern. And if that surface pattern looks like a brain or coral, then it is a type 2 and very likely adenoma. And if, on the other hand, you see a lot of irregularity and disrupted or missing blood vessels or ulcerations, then it's very likely type 3 and a cancer. We have a picture of this also posted in our GI unit so people can reference it. Again, there are many, many classification schemes, but I actually think that the NICE classification is the simplest one to remember. There are just 3 categories: type 1 hyperplastic, type 2 adenoma, type 3 invasive. And I think this can really help guide your decision making. In particular, if we see that the classification looks like a nice type 2 and adenoma, that brain-like or coral pattern, we can prepare for EMR or prepare for future EMR by tattooing nearby. Typically, you don't need to biopsy these. If it looks like a straightforward adenoma, no need to biopsy. There's a concern that too many biopsies can actually potentially lead to scar tissue and make a polyp harder to resect. On the other hand, if there are lots of disrupted vessels and it looks very irregular under NBI, that's a great one to biopsy because that may be a cancer. And you'll also typically want to tattoo this nearby. So getting back to my overall take on the web of polyp classification schemes, I think the most important message is not to miss the forest for the trees. Yes, you should pay attention to morphology and shape, which is the Paris classification. Yes, you should pay attention to the surface pattern, and the NICE classification in particular is a good way to do it. JNET is one step more complicated. But the far more important thing than memorizing classification schemes is just to recognize some key patterns that may change your management. If there is central depression, that's the Paris classification. If you see central depression, that's bad news. If you see interrupted surface vessels on NBI, that's bad news. Recognizing these patterns can guide correct decision-making for resection, biopsy, tattoo, etc. All right, so let's get the tattooing right. Tattooing is an area that actually goes awry more frequently than you would think, and there are a couple of reasons for this. The key concepts around tattooing is you want to tattoo an area that is at least about 3 centimeters away from the lesion. Tattoo typically spreads pretty quickly over the course of a few hours or a few days. We see very, very frequently that folks have tried to tattoo nearby a lesion, and then very quickly, by the time they see us for advanced resection, the tattoo is spread under the lesion. And that can sometimes cause some scar tissue and make resection more difficult. If you want to get fancy, you can tattoo in a couple of different orientations at 3 o'clock and 9 o'clock. It might help the surgeons find it more easily when they enter the abdomen. Our surgeons typically want just a distal tattoo. You should talk with your own local surgeons about their preference. The problem with a proximal and distal tattoo is that if a surgeon gets in there and sees only one tattoo, they do not know whether the polyp is distal or proximal to it. On the other hand, if you only place distal tattoos and the surgeon finds the tattoo, they know that the polyp is somewhere proximal. So generally speaking, tattooing distal only to the polyp is the better approach. And then the technique there, how to get that submucosal bleb is a little bit of a challenge, and there are two ways to do it. The most reliable, cleanest way to do it is to actually inject, to create a bleb first with just saline. You are able to find the submucosal space just as easily as you can with ink, but you're not spraying saline all over the place as you're finding it. And so it's a very, very clean way to create a bleb. And once you've created that bleb, then you can go into that bleb easily with ink. If you're confident you can hit the submucosa the first time, then absolutely you can use ink to start with. But you have to be just a little bit careful because it's very easy to go a little bit too deep, a little bit too shallow and make a mess. And so, so the goal here is to find the submucosa, and you typically have to go fairly tangential to the lining to get that angle right. So saline bleb method, super reliable and very, very clean. If you successfully inject the tattoo, this is what the surgeon sees. And if you unsuccessfully inject the tattoo, sometimes they'll see peritoneal staining throughout the whole abdomen. And it's not generally harmful to the patient, but doesn't necessarily give them a lot of, give the surgeon a lot of confidence in your technique if you've sprayed a tattoo all over the abdomen. All right, so if we decide to go ahead and take out the large sessile polyp, let's talk about the approaches to actually doing that. There's an evolving landscape of techniques from hot versus cold, from EMR to ESD, whether we should use submucosal lift versus water immersion. Do we need to aim for en bloc versus piecemeal? And this ultimately is basically all about balancing competing clinical trade-offs. If we're thinking about bleeding risk and minimizing bleeding risk and improving overall safety, cold snare EMR is the best. Without heat, you can't do a lot of damage and there's virtually no delayed bleeding. On the other hand, if we're thinking about recurrence risk, en bloc, which for a large polyp typically requires hot resection, is best. And so this is just competing clinical trade-offs. There's not a single best approach for every polyp. And then there are also efficiency and cost issues. En bloc or hot resection can often be quite a lot faster than a piecemeal cold resection. When do we use submucosal injectate? Well, essentially, it's really two reasons that we'll use it. One is if we just need to change the shape of the polyp. We need to lift it to make it more polypoid so that we can capture it safely with the snare. And the second reason we may use a submucosal injectate is if the margins are just difficult to see. That's pretty much the role of the submucosal injection. If you feel like your snare is slipping off the edge of something, a submucosal injection will generally make that better. Proprietary submucosal agents have really taken on a somewhat dominant space in lifting currently. That had to do with convenience and also with the fact that methylene blue has actually gotten increasingly expensive. So these are actually now fairly cost competitive choices. And the lifting agent lasts longer and is pre-prepared, so it's a little bit easier. All right, so let's talk about these differences between hot and cold snare EMR techniques. With a cold snare, we've lifted, and we're going to get much smaller pieces. It's going to take longer. There's going to be more oozing. There's going to be more oozing at the moment of, but very rare delayed bleeding. And the role of injection here is really just to alter the 3D shape of the polyp. We're not trying to protect the wall of the colon because the cold snare is really not going to go through the wall of the colon. It can only really go through surface tissue. Moving over to the hot snare on the right here, we can get much larger pieces with a hot snare. It's more efficient for a really big chunky polyp, and we might be able to get en bloc if the polyp fits fully in the snare. There's generally less oozing at the time of. It feels cleaner, but it's at the cost of more delayed bleeding because of that evolution of the cautery damage. And here the role of the injection is not just to alter the 3D shape of the polyp, but here it really is to create a safe space between your cautery and the muscularis. So these are different approaches. They have different goals, and you may in your practice want to use both of them in certain circumstances. This cold snare EMR revolution, it's hard to escape. The typical approach here, just so you know exactly how to do it, is it will typically use a submucosal lifting agent. I typically don't add epi, but some folks like to do it, and this is how you do it. We typically use a 10 millimeter thin wire snare, so it will really slice through and almost snap through mucosa. And the goal is to have at least a 3 millimeter normal tissue margin. We typically have to watch the site for about a minute afterwards just to make sure there's no persistent oozing. Often there can be very early oozing, but in most cases it's going to disappear after about a minute. Is this the way forward? Should we be doing cold snare EMR for everything? Some folks think the answer is yes. I think the answer is more nuanced. There's no question that early data suggests that the cold snare EMR reduces the delayed risk of bleeding. You might not need to use as many clips. But there is some suggestion that we may have slightly higher incomplete resection or recurrence rates. Now, these can usually be managed at the time of the follow-up colonoscopy, but it's still something to consider. So my approach, frankly, is a little complex. I wish I could distill it down to less than this, but it is what it is. So if the hot snare allows me to do a one-piece on-block resection, that's pretty much what I'm going to choose for efficiency. If it's a big, bulky sessile polyp, I'm also going to choose hot snare, usually for efficiency. I don't want to have to do 19, piecemeal removals. On the other hand, if I'm really worried about the bleeding risk, I'll certainly use a cold snare. And if the polyp is super, super flat, the cold snare often grabs the edges a little bit better. Sometimes I'll use a combination. I'll use hot snare for the majority, and then I'll switch over to a cold snare to get a couple of edges that are being a little bit pesky. A couple of additional important tips. When you're doing an EMR, there's quite clear evidence that ablating the clean appearing edges is important. Most of this data came from the hot snare world. Maybe it's less important if you're being super diligent, taking lots of clean margin with the cold snare, but I typically still do some ablation. It used to be that we would often use the APC for edge ablation, and we've moved much more towards using just the snare tip for edge ablation. You should talk with your cautery device rep around snare tip settings for edge ablation because you typically want to use slightly lower energy. But it's fairly efficient and saves the cost of getting the APC probe out. The second important tip is that there is fairly clear data that clip placement, it makes sense for at least right-sided colon polyps greater than 2 centimeters. Certainly in the hot snare world, that seems to be the right approach. And this reduces the risk of post-procedural bleeding. I'll make one other comment because this paper made a lot of press a couple of years ago around the clip placement story of the paper. But there was also a blue petal versus yellow petal or endocut versus coag current story of the paper as well. There was a randomization of current, and there was actually no difference in any of the clinical outcomes for using endocut versus coag for these EMRs. So I tend to prefer endocut currents. You'll find folks that are very passionate about using one current or the other. But the truth is, this paper shows that they're probably equivalent. A couple of comments about underwater EMR, which you're probably hearing about more and more. The concept of underwater EMR is that there's a recognition that if you fill the lumen fully with saline, it basically causes the submucosa to float up and moves the polyp further away from the wall. One of the big advantages of underwater EMR is that it doesn't cause the polyp to grow larger. One of the sort of counterintuitive aspects of EMR for colonoscopy is that we see a large polyp and we say, oh gosh, this is such a large polyp, I'm going to do an EMR. And what's the first thing we do? We inject it and we make it like twice the size. So underwater EMR avoids that problem and keeps the polyp fairly small while having it float away from the wall. I'll show you a quick video of what this looks like. This is becoming increasingly popular in Japan. This is fully underwater, no injection beforehand. Typically, I want to do this with a hot snare because there's a lot of oozing that can occur otherwise, and underwater oozing is no good. But you can get really, really clean, beautiful resections with this underwater technique. As a starting point, my recommendation is to consider using it in a polyp that's giving you trouble. If a polyp's not lifting well, or you're getting into, or you have a scarred polyp that's been partially removed before, and you just can't quite get it up into the snare, underwater technique is a really, really nice tool to solve that problem. So a couple of final thoughts as we finish off. I think one of the key stories that is important to remember is that we have a ton to offer our patients for large polyps. And in 2024, there are still far too many patients who are undergoing surgery for benign polyps. In fact, the estimates are that there are 500,000 to 600,000 surgical colonic resections in the United States yearly, and the majority of these are not for diverticular disease. The majority of these are actually for benign, potentially resectable colon polyps that have never been evaluated for endoscopic resection or EMR. So when this has been looked at, if you have patients who are routed to a colorectal surgery team, and that colorectal surgery team is thoughtful enough first to say, well, let's take a look at this by an advanced endoscopist, it turns out that about 80% of adenomas that are referred to colorectal surgery can actually be removed successfully endoscopically. So this is a really important message, and we see patients all the time here at Beth Israel who were originally told somewhere in the country in New England that they needed to see a surgeon for their polyp to come out, and then they see us and we're able to get it out successfully without the need for surgery. I think of advanced endoscopy really essentially as a surgery-sparing field, and my recommendation is if you are inclined to send your patient for surgery because you think the polyp is just too big, always have a discussion with one of your local doctors who can do advanced resection. So our best practice for this for 2024 key points: small sessile polyps, incomplete resection is surprisingly common. These are the most common polyps. We want to get these right. We should aim for en-bloc resection with a cold snare whenever possible. For large pedunculated polyps, if there's a thick stalk, hemoclips may be just as effective as an endoloop. Now at least you know how to use the endoloop with the ABA method. So either of those approaches are fine, as is epi injection if you wish. And then for large sessile polyps, I'd really encourage you to learn some of the basic concepts of the Paris and the NICE classifications, but not get bogged down in the details. Just know the general concepts around depressed polyps are an issue. We need to be aware of these, and understanding some of the general NBI patterns between an adenoma and a cancer is really worthwhile learning. If you do plan to refer for advanced resection, EMR, ESD, only biopsy if you really have a high concern for cancer. Otherwise, you know it's a polyp, we know it's a polyp. It doesn't need to be biopsied before EMR. And then if you're going to tattoo, make sure to tattoo away from the lesion, typically at least a few centimeters distally. As a reminder, this U.S. Multi-Society Task Force guideline from 2020 really nicely summarizes the approach to each polyp size. And if you want to get everybody in your unit swimming in the same direction, my suggestion is to get this posted up and have a divisional or department or group discussion about the approaches to things so that everybody is taking a fairly modern, advanced approach to dealing with polyps correctly. So with a little bit of extra time for our future discussions, I will hand back to the moderators, and thanks so much for your attention.